our Okay, good evening, everyone, and I'm really delighted to welcome us all to this another wonderful session of our Residence Academic Series, proudly powered by the Education Committee of the Nigerian Society of Anesthetists. I'm Dr. John Afamusemene, the junior representative of the Nigerian Society of Anesthetists, and it's a pleasure to have us all here. As is customary, we already have enough people on here. Thank you all for joining in. Thank you all for being on time, and we'll get into it immediately. I will be first, would want to appreciate the presence of our chief, our trainer, the president-elect of the NSA, and the chairman of the Education Committee, Dr. Pinet Kalu. Thank you so much, Ma, for being here. I think we'll get into it immediately. Okay, Chief.
Yeah, thank you very much for having me.
Oh, thank you so much, Ma. So I will get into it immediately. I would call on the moderator for today. Is Dr. Eze Chidiebere, a registrar in the Department of Anesthesia, University of Benin Teaching Hospital. Dr. Eze, how are you?
I'm fine, Chief. Good evening, sir.
Excellent. Good evening, everybody. So take it away.
All right. Thank you so much for joining in this presentation today. My name is Dr. Eze Chidiebere from University of Benin Hospital. I'm a resident doctor. So in today's topic, we are presenting acid-base disorder, presented by my colleague, Dr. Emka Ruben. So following the protocols of today's presentation, we are going to be using 30 minutes for the presentation. That will be done by Dr. Ruben. Then after the 30 minutes, we are going to use 15 minutes for question and answers. In other words, while the presentation is ongoing, you can drop your questions in the chat box and I will be collecting it so that at the end of the presentation, the presenter will be able to answer them. Afterwards, we'll have 15 minutes which we are going to use for comments from our teachers and trainers that are present here. So they will be using 15 minutes to talk to us. Thereafter, the 5 minutes that remaining will be a kind of closing remarks from the NSA executives that are present at this moment. So presently, I'm going to be inviting the presenter of today's topic, Dr. Ruben Emka, to come on stage to lead us. Sorry, before that, I want to bring to our notice that there are some rules that are guiding us to this presentation. First of all, you have to mute your devices. So we don't want to be hearing anything on the background so that you not distract the presenter or the presentation. Then you name your device to your own name because we're going to be taking an attendance while the presentation is ongoing. So your name should be there as the actual name should be what you're going to be using for this presentation. And if possible, add your center name to your name. So attendance is compulsory as regarding this presentation. So at this point in time, I will be inviting Dr. Ruben to come on and do his presentation. Thank you all.
Okay, thank you very much for this opportunity. We'll be going through the topic acid-base disorders. We'll be following this outline. We'll start from the introduction all the way through to measurement of blood gases, gases tension and pH, and then we'll look at some scenarios, and then we'll to try to determine what type of disorder will be there to test our understanding of the topic, and then I'll conclude. Acid-base, okay, metabolic processes in the body and some drug metabolism lead to the production of hydrogen ions. If left to accumulate, they will be deleterious to the body. The body is endowed with mechanism that helps in regulating the hemostasis of hydrogen ion. And this is usually termed as acid-base balance, and is of great importance to we, the anesthesiologist. Hydrogen ion concentration in the body is usually kept within a narrow range of between between a pH of 7.35 to 7.45, which correspond to a plasma concentration of 36 to 44 nanomoles per liter. Excessive production of acid or bases and or disorders of the regulatory systems lead to acid-base disorders. We'll define some certain terms quickly, which will be used during the course of our presentation. An acid is basically defined as a substance that donates hydrogen ion, while a base is a substance that accepts hydrogen ion. A strong acid is that which donates hydrogen ion irreversibly and then increases hydrogen ion concentration, while a strong base binds hydrogen ion irreversibly, thereby decreasing the concentration of hydrogen ion. A weak acid reversibly donates hydrogen ion, while a weak base reversibly binds hydrogen ion. Biological compounds in the body can be classified either as weak acids or weak bases. Now, for a conjugate base, a conjugate base is the dissociated anion of an acid. Usually, when an acid dissociates in a solution, it usually gives off hydrogen and a conjugate base. And usually, for weak acids, such as carbonic acid, when they dissociate, they give rise to a strong base or a strong conjugate base, while strong acids usually give rise to weak conjugate bases. And then the same also implies for the bases. Now, what is the strong ions? Are those ions that completely dissociate at physiological pH. The most abundant strong ions in extracellular space is the sodium for cation and then chloride for anion. Others that are also equally important include the potassium ion, magnesium, and calcium ion. The strong ion difference is the difference between the strong cations and then the strong anions in the extracellular fluid. And the value usually ranges between 40 to 44 milli equivalent per liter. Now, the importance of this is that usually when the strong ion difference decreases, it leads to more free hydrogen ion, which leads to metabolic acidosis. This means that when the strong ion difference decreases, that means the cation concentration is decreased. So for the body to maintain electron and neutrality, it will usually increase reabsorption and conservation of hydrogen ion, which is also positively charged, so as to increase the strong ion difference back to the normal physiological value. Then when strong ion difference increases, there's less free hydrogen ion and then metabolic alkalosis occur. The same explanation can be used for this also. Now, the pK or pK, which can be used synonymously, is the negative log of the ionization constant of an acid. Now, the pK is the pH at which an acid is half dissociated, existing in equal proportion as an acid and then a conjugate base. Now, for strong acid, the pK is usually less than 3, while for strong bases, the pK will be greater than 9. pH is defined as the negative log of hydrogen ion, and it represents the hydrogen ion concentration in the body. The hydrogen ion concentration in the body is mostly reported in terms of pH, not the serum concentration itself. Now, acidemia is arterial pH less than 7.35, while alkalemia is arterial pH greater than 7.35. Now, usually these words are sometimes used interchangeably. The pair of words are usually used interchangeably: acidemia, alkalemia, acidosis, and alkalosis. But in the real sense, acidosis is actually a pathological process that leads to acidemia with clinical manifestation. The same can also be said for alkalosis. Now, we'll look at the compensatory mechanisms in the body, the mechanism in which the body usually uses to maintain hydrogen ion homeostasis. The mechanism include the chemical buffer, which is the first mechanism employed by the body and is the immediate response that usually occur from any derangement in hydrogen ion. Then we'll have the respiratory compensation, And then we'll have the renal compensation, which is the most effective, but it's very slow in its process. For chemical buffering, a buffer basically is defined as a weak acid and its conjugate base. And we all know that weak acids usually have strong conjugate base, and that conjugate base is usually the one that is usually responsible for the buffering effect of that buffer system. And then a buffer generally is a combination of weak acid and its conjugate base, which acts to minimize any change in hydrogen ion concentration that will occur if a strong acid or base were added to it. Example of a buffer, you have the carbonic acid and then bicarbonate ion buffer system. Like I said, buffers represent a very important defense against changes in hydrogen ion. Now we'll look at the Henderson-Hasselbalch equation, which usually expresses the relationship between the pH and then the buffer. Usually in aqueous solution, the pH is determined by the concentration ratio of the acid and its conjugate base. So if this ratio, if the conjugate base is increasing, that means the pH generally is also increasing. While if the acid is increasing, the pH is usually decreasing, like that. So the buffering capacity of a buffer system is greatest when the pH is equal to the pKa. Now, these are some of the buffers we have in the body, the physiological buffers in the body. The bicarbonate buffer being the most important and the one that does most of the work. Up to 52% of the buffering capacity of the body is done by the bicarbonate buffer. Also, we have the hemoglobin buffer, which buffers up to 35% of the buffering capacity of the body. The others as mentioned there. This table just shows us the acid, the buffers, and then their buffer pair, the acid buffers, and then their buffer pairs. Okay, we'll look at the bicarbonate buffer. The bicarbonate buffer is the most important buffer in plasma. It has a pKa of 6.1. That means that's the pH at which half of it is dissociated into its acid and conjugate base. The ratio of the acid to base is approximately 20:1. And then its effectiveness is usually based on the fact that bicarbonate has a relatively high concentration in the extracellular fluid. Hence, it can be mobilized in cases of deranged hydrogen ion hemostasis. The ease with which the lung disposes or retains CO2. Usually, CO2 is also produced due to the byproduct of metabolism of some processes in the body. So it's not only produced by the respiratory system, but also systemically. So usually, whenever it's produced, the lungs can easily dispose of CO2 if needs be, or retain CO2 as the case may be. Then the third reason is that the ease with which the renal tubules can increase or decrease the rate of reclamation of bicarbonate from glomerular filtrate. We'll look at that later during the renal compensation. Now, for the bicarbonate buffer, this is the Henderson-Hasselbalch equation for it. And then if you derive further, you are going to derive a pH of 7.4, which means that this is usually the pH at which the bicarbonate buffer usually aimed at buffering the plasma towards a pH of 7.4, which is within the normal pH of the body. Now, this slide is just telling us the relationship between the concentration of hydrogen ion concentration in the body and then the pH. It's below pH of 7.4, hydrogen ion concentration increases by 1.25 nanoequivalent per liter for each 0.01 decrease in pH, while above pH of 7.4, hydrogen ion decreases by 0.8 nanoequivalent per liter for each 0.01 increase in pH. This table just shows us the relationship between pH and then the plasma ion concentration of hydrogen ion. If you look at it very well, it has an inverse proportional relationship, so that when the pH is low, which tends towards acidosis, acidemia the hydrogen ion concentration in plasma is usually very high. Now we'll look at let's quickly look at the hemoglobin buffer. The bicarbonate buffer usually is not effective against the partial increases in partial pressure of CO2, arterial partial pressure of CO2, and changes in bicarbonate ion do not reflect the severity of respiratory acidosis. Hence, bicarbonate buffer is effective against non-volatile and also carbonic acids in the body. Now, hemoglobin is the most important non-carbonic buffer in the extracellular fluid. In contrast to bicarbonate buffer, hemoglobin is capable of buffering both carbonic acid and non-carbonic acid in the body. The hemoglobin buffer system works in conjunction usually with bicarbonate buffer system. Each hemoglobin molecule, the histidine residue in hemoglobin molecule is usually the one that usually binds hydrogen ion, while the imidazole group is the one that is usually responsible for the buffering capacity of the hemoglobin. The hemoglobin buffer has a pKa of 7.2, which is usually very close to the physiological with the plasma pH. Now, this just shows us how bicarbonate ion is generated from erythrocyte from the hemoglobin buffering system. And then it also tells us about chloride shift. Usually, when plasma CO2 diffuses into red blood cell from the ICF, it now reacts to water, which is usually categorized by carbonic anhydride, leading to formation of carbonic acid. And then the same enzyme catalyzes the dissociation of carbonic acid given bicarbonate ion and then hydrogen ion. The bicarbonate ion moves out of the cell back into the extracellular fluid to help in increasing the pH, while the hydrogen ion is usually buffered by hemoglobin. Now, for bicarbonate ion to move out of the cell is usually in exchange with chloride, and that is usually termed the chloride shift. The phosphate buffer, which is present in the ECF, ICF, and then it's also a urinary buffer. It has a physiological pH of 7.4 and then a pKa of 6.0. The ammonium buffer mainly acts as a urinary buffer mainly, and then it has a pKa of 9.8. Now, for the respiratory compensation, chemoreceptors within the brainstem are responsible for the respiratory compensation from changes in the arterial partial pressure of CO2. These receptors respond to changes in cerebrospinal fluid pH, leading to increase in minute ventilation. Respiratory compensation responses are also important in defending against marked changes in pH during metabolic disturbances. Decrease in arterial pH stimulates medullary respiratory centers, which result in increase in minute ventilation, leading to washing off of CO2, which lowers the PCO2 and then tends to restore arterial pH towards normal. The respiratory response to lower PCO2 occurs rapidly, but does not reach a steady state up until 12 to 24 hours later. pH is never completely restored during respiratory compensation, and the PCO2 usually decreases by 1 to 1.5 millimeters of mercury, below 40 millimeters of mercury for every 1 milliequivalent per liter decrease in the plasma bicarbonate above normal level. Now, increase in arterial pH usually depresses respiratory centers, and then the resultant alveolar hypoventilation tend to elevate PCO2. Hypoxemia as a result of the progressive hypoventilation will eventually activate oxygen-sensitive chemoreceptors. This stimulates ventilation and limit the compensatory response. So usually in metabolic alkalosis, the respiratory compensation is usually not predictable, as we can see here. It starts well, but then due to hypoxemia, the reverse now starts occurring. And then for the renal compensation, The kidneys usually exert a major influence in pH during acid-base disturbances due to their ability to, first of all, control the amount of bicarbonate reabsorbed, form new bicarbonate, and then eliminate hydrogen ion from the body. These mechanisms are usually present immediately when acid-base disorders occur, but are not usually appreciable up until 12 to 24 hours and might reach maximum levels up to 5 days. Now, for the increased reabsorption of bicarbonate, the proximal tubules normally reabsorb up to 90% of filtered bicarbonate load alongside with sodium, while the distal tubules absorb up to 10 to 20%. This usually decreases urinary pH as low as 4.4. Now, increased excretion of titrable acid. After all the bicarbonate in tubular fluid is reclaimed, the hydrogen ion secreted into the tubular lumen can combine now with hydrogen. It can now combine with hydrogen phosphoric acid, which will now usually form dihydrogen phosphate. Now, the dihydrogen phosphate is not readily reabsorbed and is eliminated in urine. So that elimination usually goes along with the hydrogen ion that is usually secreted. When urinary pH approaches 4.4, however, the phosphate reaching the distal tubule in the form of dihydrogen phosphate form. Since you don't have hydrogen phosphate no longer to be able to titrate the hydrogen ion that is usually secreted. That now brings about the ammonium buffer into play. Now, after complete reabsorption of bicarbonate and consumption of the phosphate buffer, the ammonia/ammonium pair become the most important urinary buffer. Now, the ammonia usually gotten from the deamination of glutamine in the mitochondrium, and then acidemia usually increases this deamination of glutamate to form ammonium. The ammonium form is then able to passively cross the cells, enter the tubular fluid, and then react to hydrogen to form ammonium. Ammonium does not really penetrate the luminal membrane and is excreted in urine, effectively eliminating hydrogen ion in the process. If you can look to your right, there are some pictorial diagrams that are usually explaining these processes that I'm talking about. Now, what is the renal compensation during alkalosis? The large amount of bicarbonate normally filtered allow the kidneys to rapidly excrete large amount of bicarbonate if necessary. So since large amount of bicarbonate is reaching the kidney in alkalosis is now able to excrete more bicarbonate so as to maintain the pH of the body. Let's quickly look at base excess. Base excess can be defined as the amount of strong acid or base needed to titrate 1 liter of blood back to a pH of 7.4 at a PCO2 of 40 millimeters of mercury and temperature of 37 degrees centigrade. It is used for the assessment of metabolic component of acid-base disorders. Usually, a negative base excess indicates that the patient has metabolic acidosis, while a positive base excess indicates metabolic alkalosis. The range is usually between minus 2.5 to plus 2.5 millimoles per liter. Let's look at acidosis. What usually happens in acidosis? Now, the physiological changes associated with acidosis include it has a direct depressant effect both on the myocardium and then the smooth muscles in the body, thereby leading to resulting in progressive hypotension. It also causes tissue hypoxia despite shifting the hemoglobin curve to the right. There's also reduction in threshold for ventricular fibrillation, and then there's progressive hyperkalemia as a result of movement of potassium out of the cell in exchange for extracellular hydrogen ion in order to maintain electro neutrality. Then there's also CNS depression, often termed as CO2 narcosis. This one is usually more common during respiratory acidosis. Now, respiratory acidosis is defined primarily as increase in the arterial partial pressure of CO2. The increase in the arterial partial pressure of CO2 usually drives this reaction rotated here to the right, thereby forming more hydrogen ion in the process. The increased blood partial pressure of CO2 may be a primary process or secondary from compensation from metabolic alkalosis. These are some of the causes of respiratory acidosis, starting from the CNS. Anything that depresses the CNS usually leads to hypoventilation, which would lead to retaining CO2. Neuromuscular disorders such as Guillain-Barré syndrome, myasthenia gravis can progressively progress, leading to respiratory embarrassment, which will lead to retention of CO2. Chest deformations, which will limit expansion, long chest compliance, can also lead to increased CO2. And then pleural effusion and pneumothorax can also lead to CO2 retention. Airway obstructions, and then parenchymal diseases such as pulmonary edema, and then ventilator malformation can also lead to it. And then causes that are due to increased CO2 production, which is usually seen in malignant hyperthermia, intensive shivering, prolonged seizure activity, thyroid storm, and then external thermal injury such as burn, and then large caloric load. Respiratory acidosis is usually a response to acute elevation in partial pressure of CO2. It's limited, with hemoglobin being the primary buffer. Now, renal response to retain more bicarbonate is acutely very limited also. But plasma bicarbonate increases only 1 milliequivalent per liter for each 10 millimeter mercury increase in the partial pressure of CO2 above 40 millimeters of mercury. That means in the acute phase, the response, the compensatory response is usually very limited. Renal compensation is appreciable only after 24 to 48 hours. And then in renal, during chronic respiratory acidosis, plasma bicarbonate level increases approximately 4 millimeters per mercury per liter for each 10 millimeters per mercury increase in partial pressure of CO2 above 40 millimeters of mercury. What is the treatment for respiratory acidosis? The treatment mainly will be aimed at increasing alveolar ventilation in order to, via controlled ventilation. It can also be specific by the use of bronchodilators in cases of asthma or COPD to improve, to cause airway bronchodilation. Use of diuretics in cases of pulmonary edema. Use of reversal of, you can also reverse narcosis in case of increased narcosis. Now, reducing CO2 production in specific instances also can help, such as the use of dantrolene in malignant hyperthermia, muscle paralysis in cases of tetanus or seizure disorders, and then anti-thyroid medication for thyroid storms, and then reduce calorie intake for patients that are on enteral or parenteral nutrition, so as to decrease the amount of CO2 that is usually produced from the metabolic breakdown of carbohydrate and fatty acid. Oxygen therapy can also be used in order to increase the FiO2, because usually respiratory acidosis is usually accompanied by acidemia. So use hydrogen therapy will help improve this. And then the use of sodium bicarbonate therapy is usually indicated if the pH is less than 7.10, and if the hydrogen ion concentration, if the bicarbonate ion concentration is less than 15 milliequivalents per liter. Now, therapy in patients with chronic respiratory acidosis, such as COPD, should be returned to patient's normal, but not normalized to 40 millimeters of mercury. This is because in this patient, they are already used to the high levels of partial arterial pressure of CO2, and hence their respiratory drive is now solely dependent on the oxygen concentration. So reduce oxygen therapy, which will usually increase the oxygen concentration and decrease the partial pressure of CO2, will usually lead to hypoventilation, which usually occurs due to reduced stimulation of the respiratory centers in those patients. Now let's quickly look at metabolic acidosis. Metabolic acidosis is defined primarily as decrease in bicarbonate ion concentration. This can occur via three processes. It can occur due to consumption of bicarbonate by a strong non-volatile acid, or renal or gastrointestinal wasting of bicarbonate, or rapid dilution of extracellular fluid compartment with bicarbonate-free fluid. Now, compensation for metabolic acidosis occurs through the stimulation of respiratory centers, resulting in hyperventilation to wash out CO2. The difference, let's look at what ionic gap is, because it's very important when we are discussing metabolic acidosis. Ionic gap is the difference between the measured cations and the measured anions. So usually, basically the difference between sodium ion and then the major plasma anion, which include chloride and then bicarbonate ion. Some authors will usually use sodium and potassium ion. So whichever author you come across, we should still be familiar with it. Now, the normal value is usually between 8 to 16 milliequivalent per liter, but this also depends on the author you are using. It can also be expressed as unmeasured anions minus unmeasured cation. Now, this is usually because for electron neutrality to occur in the body is always driving towards electron neutrality. So electron neutrality must be maintained at all times. So you cannot have a difference between cations and anions. This difference only occurs because we can only measure some certain cations and some certain anions usually. Unmeasured cations will include calcium ion, potassium ion, and magnesium.
Dr. Ruben, please can you be able to summarize like in the next 2 to 4 minutes? Because of time.
Yes, I'll do that.
All right.
Now, the anion gap is significant only when the value is greater than 30 milliequivalent per liter. Now, usually plasma albumin usually exert the largest fraction of ionic gap in the body, and then the anionic gap can be calculated based on the corrected value from in patients with hypoalbuminemia as ionic gap plus 0.25 times 40, which is gotten from albumin, which is usually expressed in grams per DL. Now, metabolic acidosis can either be high ionic gap metabolic acidosis or normal ionic gap metabolic acidosis. Now, high ionic gap metabolic acidosis is usually characterized by relatively strong non-volatile acids, and the causes are as follow. There's a mnemonic here for the causes of ionic gap metabolic acidosis, which is MODPIE's CAT. And we can see those causes there: methanol, uremia, DKA, all the way to filling injection. Now, normal anionic gap metabolic acidosis, which is also referred to as hyperchloremic metabolic acidosis, usually occurs due to commonly occur due to abnormal gastrointestinal or renal losses of bicarbonate, or from excessive intravenous administration of sodium of 0.5% sodium chloride. Now, these are some of the causes, but again, we have a mnemonic for the causes, which is used CAR, which stands for urethral diversion, basically fistulas that can lead from diversion of urine to other places, thereby losing bicarbonate in the process. And then chloride is usually reabsorbed in order to maintain electron neutrality, all the way to renal tubular acidosis. Now, we'll quickly talk about what renal tubular acidosis is. It's a disease of systemic acidosis which results from defective renal compensation. We have from type 1 all the way to type 4. Type 1 being a defect in the distal renal tubular hydrogen ion secretion, while type 2 is involved the proximal renal tubular reabsorption of futile bicarbonate. Now, treatment mainly is to correct the underlying cause mainly, but then sodium bicarbonate may be required if pH is persistently low or less than 7.2 millimeter, 7.2. Now, serial blood gas measurement is usually done to avoid complications which will result from the therapy, such as overshoot alkalosis. Now, specific therapy can be done for specific conditions such as diabetic ketoacidosis, in which you give intravenous fluid, which will aid in osmotic diuretic, administer insulin, which will usually help glucose enter into the cells, and then administration of potassium chloride, which will usually help correct hypokalemia. For lactic acidosis, is usually aimed at adequate oxygenation and then adequate tissue perfusion. For salicylate poisoning, you do alkalination of urine, which is usually done with the use of bicarbonate. While for methanol ethylene glycol intoxication, we usually treated with ethanol or fomepizole, which is a alcohol dehydrogenase inhibitor, and then dialysis can also be done. Now, the bicarbonate speed basically tells us about the volume of distribution of bicarbonate in the body. And then it also helps us calculate the amount of bicarbonate that we usually require in order to correct for metabolic acidosis. The formula is here. It's a very familiar formula for all of us. The Winter formula basically helps us, is used to evaluate respiratory compensation when metabolic acidosis is present in a patient. So usually it tells us whether the respiratory compensation in metabolic acidosis is adequate or not. And this is the formula that we usually use it for. Now, what are the anesthetic considerations in a patient with acidosis? Usually, acidosis usually causes a depressant effect, both on the CNS and then the CVS, which will potentially lead to hypotension in this patient, usually. And then also, acidosis usually increase the opioid penetration into the CNS, thereby exerting a sedative effect. It also usually causes, exaggerate the arrhythmogenic effect of halothane, and then it causes and worsens hyperkalemia. Now, alkalosis, the physiological effect of alkalosis basically is that it causes hypokalemia. It shifts the oxygen dissociation curve to the left, basically, thereby causing tissue hypoxia. It reduces cerebral blood flow, and then it usually increases bronchial smooth muscle tone, thereby leading to bronchoconstriction. The causes can either be central, such as anything basically that can cause increased minute ventilation in a patient can result to respiratory alkalosis. And some of the causes are usually here for us to see. For metabolic alkalosis, usually defined as increase in plasma bicarbonate concentration. And it can either be chloride sensitive or chloride resistant. Chloride sensitive is usually associated with sodium chloride deficiency or ECL depletion. An example are as follows. While the chloride resistant are usually due to enhanced mineralocorticoid activity. And then the examples are here as follows. Other causes of metabolic alkalosis can be due to excessive administration of alkaline, which usually occurs in exchange resin therapy, massive blood transfusion, and then the milk alkaline syndrome. Compensation is usually mainly by induction of respiratory acidosis by CO2 retention. What are some of the anesthetic considerations for a patient with alkalosis? Usually cause marked respiratory alkalosis with hypotension can cause cerebral ischemia because the cerebral vessels are constricted and blood is not getting to the brain. Now, alkalosis together with hypokalemia can precipitate severe cardiac arrhythmia. Now, we'll quickly look at how we can measure blood gases tension, and then the pH. Measuring of arterial blood is usually used to measure acid-base parameter. The assessment of acid-base status is usually done by blood gas analyzer. And then the directly measured parameters from this analyzer are the pH, PCO2, and then the PO2. While other directly measured parameters can be electrolytes such as sodium, potassium, chloride, and then calcium, lactate, glucose, and then the hematocrit. Indirectly measured parameters are the ones mentioned here. Now, from the value of these parameters, sodium ion, potassium, chloride, and then bicarbonate, the ionic gap is usually calculated, and then the analyzer usually displays the ionic gap. This is just showing us some of the normal values of some of the values that are measured during blood gas analysis. Now, let's quickly look at how we can acid-base disorders. For diagnosis of simple acid-base disorder, the first thing you look at the pH. Is the pH increase or decrease? If the pH is decreased, that means you're dealing with acidemia. Now, after that, you look at the PaCO2. If the PaCO2 is decreased, that means the cause of the disorder is usually metabolic, which will be metabolic acidosis. But if it is increased, that means the cause is usually respiratory, which will be respiratory acidosis. You apply the same thing on the other side in order to diagnose it. Now, for diagnosing complex metabolic acid-base disorders, it's usually a bit more complex than this. First thing is first, you look at the oxygenation. Is the oxygenation adequate or not? Usually for patient, usually the partial pressure of oxygen, arterial partial pressure of oxygen should be 3 to 5 times the FiO2 of the patient, especially for patients that are on oxygen and therapy. So you keep that in mind. Then you check whether are we dealing with acidemia or are we dealing with acalemia. If this acidemia, we have to determine whether the acidemia is primarily of respiratory or metabolic, or it is mixed. If CO2 is high, it's respiratory in origin. If bicarbonate is low, base excess is negative, it's metabolic in origin. If both are present, that means you have a mixed metabolic and respiratory acidosis. Now, after that, you have to check whether the body is compensating or not. Now, if there's respiratory acidosis, the body is usually going to compensate by what? Increasing the concentration of bicarbonate ion in order to compensate. While if it is acidosis, the body is, if it is metabolic in nature, acidosis, the body is going to increase oxygen intake, thereby washing up CO2 and decreasing the partial pressure of CO2. You can use the same thing to apply for cases of acalemia also. At the end of it, you are going to summarize what all the defect and whether it's compensated or not. This is just a diagram that is just going to tell us how we can approach diagnosing acid-base disorders. Primarily, the disorder that is on the same side as the pH is usually the primary disorder, while the one on the opposite side is usually compensatory mechanism. This also is just telling us how the diagnosis can be made of complex acid-base disorders. This is the same table telling us conditions where we have mixed acid-base disorders. Now we'll look at some scenarios quickly. The first scenario, you have this APG present, pH of 7.25, PCO2 of 60, hydrogen bicarbonate concentration of 28, while PO2 of 60. Now the interpretation from the pH, you see that we're obviously dealing with acidemia. The PCO2 shows respiratory acidosis because it's high, it's more than 45, while the bicarbonate is slightly elevated, which shows and correlates with acute, which shows some form of compensation. So the diagnosis would be an acute primary respiratory acidosis with hypoxemia. The hypoxemia is coming into effect because the PaO2 is only 60. The minimum value of PaO2 on normal room air should be 80 to 100. The second scenario, we have this APG in front of us. The pH is 7.2, which obviously is acidemia. The PCO2 is 56, which is also elevated. The bicarbonate is 26.7, which is essentially within normal range. The base excess is 0, which is still within normal range. And then the SpO2 is 100. So from here, we can see that there's acidemia, which is of respiratory origin. So diagnosis would be acute primary respiratory acidosis, which is uncompensated. Uncompensated because the value of the bicarbonate has not changed. If it was compensated, the value of the bicarbonate will be increasing so as to be able to level up the pH to the normal value. Sorry, I'll skip to the next one. This is we have a clinical scenario here with the arterial blood gas analysis. So we have to determine the disorder that is present here. Clearly, the FiO2 is 21, means the patient is on room air. The PaO2 is 110, which is within the normal range of 3 to 5 times the FiO2, and which is, sorry, not the FiO2. The SpO2 is 99%, which the PaO2 is not up to 3 to 5 times of that. Then the pH is 7.45, which is also within normal range, while the PCO2 is 27 millimeters of mercury, which is low because the lower limit is usually 35. The bicarbonate concentration is 24.2, which is within normal range. Within normal range. The diagnosis here should be respiratory alkalosis with hypokalemia and hypocalcemia from the electrolyte present. This is another scenario which we'll skip. When we get the slide, we can look at all the scenarios. So in conclusion, a good understanding of acid-base disorders and the compensatory mechanism is crucial to the anesthetics for management of this patient, both in the intensive care unit and in the perioperative period. Early recognition and treatment of the underlying cause is essential for better outcome. These are my references. Thank you very much for listening.
Thank you, Dr. Ruben, for the presentation. We all know that this is a complex topic, but you have done justice to that. So thank you so much for this wonderful presentation. So at this point in time, we'll be taking at this point in time,
hello, good evening.
Good evening. So if you have any question, good evening. You can drop your question in the comment section at this point. So we have a first question here, which came from Dr. Charlie, if I'm pronouncing it correctly. Dr. Ruben, I don't know whether we are able to see the question. The question says, can you list the causes of fluoride sensitive and fluoride resistant metabolic alkalosis? The possible causes of that. If you have any other question, you can ask your question as I'm collecting them at this point.
Moderator.
Okay, thank you. Okay, thank you. I just wanted to mention. Please, we have, because of time also, while he's taking the question, we have our chiefs and trainers here. I think Prof wants to say something. So, Privma, you have the floor, ma.
No, I want to say that Professor Elegbe is greeting. Can we?
Okay, yes.
Allow her to.
Oh, yes, ma. Yes, that's why.
My battery, my battery is running low. Before I charge it, it might go off. What I want us to consider is metabolic and acid-base disturbance in severe peritonitis following thyroid perforation. Did we get that? Did we get that? Hello?
Yes,
Did you get that?
No,
Sorry, ma, can you repeat, please?
Acid-base disturbance and metabolic and electrolyte derangement. Acid-base disturbance and electrolyte disturbances following acute typhoid perforation. Did you get that? Low. Oh, okay.
Okay.
Did you get it? Did you get the question? Did you get the question?
Yes, ma.
Did you get the question?
Yes, ma. I got the question. It's acid-base disturbances and electrolyte derangement following acute typhoid perforation.
That's right.
Yes, ma. Sorry, I don't know if I can.
Yes, presenter, please take the questions. Just do a discussion on what Prof asked, and then also maybe highlight the other question too. But please, quickly, because you know that Prof is on the line now, so she can comment on it.
Okay, thank you, Prof, for your contribution and then the question. Now, usually in acute typhoid perforation, which usually result also with peritonitis, there's usually some form of acidosis in this patient, first of all. And we all know that acidosis usually leads to hyperkalemia, in which there's exchange of potassium, which moves from the intracellular compartment to the extracellular compartment in exchange to hydrogen ion. So there's usually hyperkalemia in this patient. And then also from typhoid perforation, there's going to be loss of fluid from the small intestine mainly. And then these fluids in small intestine are usually rich mainly in potassium, rich mainly in bicarbonate and sodium. So usually when these fluids are usually being lost, the level of bicarbonate in the body is also reduced, thereby tilting the patient also more towards acidosis. So mainly the ones I can think of right now is the acidosis, which is usually caused by loss of bicarbonate fluid, and then also the hyperkalemia that usually results from metabolic acidosis due to exchange of potassium for hydrogen ion. Thank you, ma'am.
I'm not very clear about this acidosis, the resulting acidosis. Is that all the factors that is responsible for acidosis? They have other problems, don't they? What are the signs and symptoms that, I mean, the symptoms, let's say the symptoms that typhoid perforated patient comes with? What are the clinical presentation?
Okay, ma'am. Thank you, ma'am. Yes, ma'am. The clinical presentation mainly will be that this patient is going to be febrile, usually from peritonitis and sepsis. And then due to this, the patient is, the acidosis can also result into hyperventilation.
What is causing the acidosis is what I want to get. What is, it's not clear to me. What is causing the acidosis in them? You explained it, but I didn't fully catch it. What is responsible for the acidosis?
Sorry, ma'am, I'm not hearing you very well.
What is responsible for the acidosis? How did they come to get to be acidotic? You said they are acidotic. Yeah.
Yes, ma'am.
But what are the contributions towards that acidosis? What makes them acidotic? I didn't catch your explanation well.
Okay, ma'am. Earlier when I said that due to loss of fluid from the small intestine, which usually contains mainly bicarbonate ions, these patients usually have low levels of bicarbonate, which usually leads to acidosis in these patients.
Okay.
Yes, ma'am. Okay. And then also
what about their cardiovascular system? What about their cardiovascular system?
Yes,
what is the cardiovascular system like?
Thank you, ma'am. For the cardiovascular system, acidosis can usually lead to decreased cardiac contractility and then decreased vascular tone.
No, you don't get me. What I'm saying is, when you see a patient with perforated typhoid, what is the blood pressure? What is the cardiovascular status as of the time you see the patient?
Okay, ma'am. The blood pressure is going to be low. The patient is going to be
have
hypothermia and then tachycardia.
They are usually hypovolemic.
Yes, ma'am.
When patient is hypovolemic, what happens to the microcirculation?
The microcirculation is usually reduced. So there's some form of tissue hypoxia also.
So tissue hypoxia will lead to what?
It leads to hypoperfusion, which will lead to increase in anaerobic metabolism, which will produce lactic acidosis.
That's where part of where I'm going. That's all right. That's fine.
Yes, ma'am.
You got there in the end. That's all right. That's fine.
Thank you very much, ma'am.
Okay. All right. Pleasure. Okay.
Thank you very much.
Okay.
Thank you very much, Mark. Thank you very much. So, Dr. Ruben, I don't know if you're able to take other questions. The first question that asks you to explain the chloride sensitive and the chloride resistant causes of alkalosis. And then the other question that said,
please, do you still want to make a comment? Prof.
Yes, sir. Yes. I have unmuted myself. I want to congratulate the presenter, Dr. Mka Ruben, for the brilliant presentation. My own is just to comment that the topic is really a bit broad, too broad to encourage adequate and proper understanding and comprehension. I appreciated why Professor Elegbe now made it a problem-based discussion. I will enjoin the organizers in future to probably like break it down or make it more practical to be like related to anesthesia or an anesthetic case or a problem, patient-oriented problem-based management. That way it is more practical and less, theoretical. So that's just my own comment. I appreciate everybody that has been working hard to make sure that these webinars are a reality. Thank you very much, everybody, and good evening, everybody. Over and out.
thank you, ma'am. Dr. John, I don't know, we have something to say, sir.
Okay, so thank you for the presentation. If there are no other comments, also because we spent a bit of time, I think you did well. Like Prof said, it's really a broad topic, but I feel like you're able to cover some of the basics. We'll keep refining and keep ensuring that we are making the discussions as practical as possible. I'll just say, I don't know if we have time to take the questions, so that we'll leave, because the NSA president is on the line. So we'll leave questions and comments for the NSA executives. I would, however, say, moderator, please let us collate the questions, and then the presenter will just give us the answers to those questions in maybe a document form that we will share on our group. I would also now call on, I would call on the NSA president. I think, Prof, sir, are you still here? Because of our timing. I saw him earlier.
Yes, I'm around. Thank you very much.
Thank you so much, sir. Welcome, sir. Good to have you here.
Thank you. I heard everything, and I heard Professor Elebe's comment and Professor Maso. I was thinking I've seen Professor Oshinaike, President, Intensive and Critical Care Society of Nigeria, because this topic presented is very important in the space of critical care. If he's around, please, he can unmute and say something. And then I've seen also Professor Adepisi from Kumasi, Ghana.
Thank you, Professor Datsi. I didn't really follow closely, but at least I heard some of the important things that the presenter talked about. I think he tried to cover as much area as possible, but I'm not sure if I think because the focus is more like anesthesia, an acid-base balance or so. So he did not go into maybe correction of the acid-base disturbances and things like that, interpreting ABG values and things like that. So I don't blame him for that, because I think it's more of anesthesia related, or I'm not sure if maybe I missed those parts, but I didn't hear anything about correcting those acid-base issues. or I'm interpreting the different ABG results for different situations. So, but if it's just anesthesia-based, I think it covered anesthesia-based issues when it comes to acid-based disturbances. Thank you very much.
Yeah, thank you, Professor Shinake. I think you're right, but it's a broad topic, and that comes to the fore that you can have a topic to cover critical care setting. Also, I want to say that if you had maybe use some examples, I mean, some results from the blood gas analysis to illustrate some of these disorders, that would have been great. Professor Mwaso, your hand is still up, or was it the first time?
It's an old hand. Let me lower it.
Okay,
I'm sorry.
okay, thank you. Professor Antiokusi, please unmute and say something, if you are still around. Okay.
I think he left. I saw.
I think he left. Okay. So thank you very much. This topic is very important, and I think this is an overview. There are many things that you can add to this for further reading, and also where you have blood gas analysis, analyzer machine in your ICU settings. Please make use of them, and the way to learn this is to keep looking at those results over and over again. Then you will have a full grasp of the topic. I'm sure even in the exams, you have interpretation of this as in the 1 or 2 OSCE stations. So this topic is very important for residents going for exam. I don't know if the PRO is around, please, if you have some announcement for us. Dr. Nana, if you're around.
Yes, I'm around. Good evening. I don't know if I can be here. Yes, thank you for the presentation. Good evening, everyone. I just have brief announcement today. All members of NSA are kindly encouraged to make their annual dues payment as has been advertised on the chat box. Also, we encourage everybody to join our social media handles, NSA Nigeria on Instagram. All our, as soon as possible, we are going to
working with animistic compartmental models.
Sorry, I can't hear him again.
Yes.
Okay.
Yes.
Okay. Are you done?
No, Prof. I think,
okay. Okay. So is there anything else, President-elect, Chair Education Committee?
Just to say a very big thank you to everyone. I agree it was a very broad topic, and we have gone past our usual time. We try to keep to time. Thank you for keeping faith with us. We'll make the link available, and then we'll also try to link you up with the answers to some of the answers that were not addressed during this meeting. Thank you, everybody, for your kind contributions, and keep a date with us next time.
Thank you. Goodbye, everybody. The link
Good night, Mr.
to
President.
the
Good night,
presentation will be shared as soon as it is available.